Swayam Prabha. Digital India. Educated India.
Welcome to today's session. With this lecture, we will be starting a new series on gastrointestinal tract infections. These are the second commonest infections which you will see in your medical clinics, the commonest being respiratory tract infections. Today's lecture focuses on diarrheas. Today's lecture, we will be discussing under the following headings: definition of infections of the gastrointestinal tract, the prevalence of diarrhea, its epidemiology and causative agents, the presentation of a typical case of E. coli diarrhea. We will be following up a case with you, and we will be discussing the diarrheogenic E. coli, their presentations, pathogenesis and diagnosis. Diarrhea is defined by the World Health Organization as having 3 or more loose or liquid stools per day, or as having more stools than is normal for a person, though usually formed stools are not taken as diarrhea. Persistent diarrhea is diarrhea lasting for 14 days or more. Dysentery is an infection of the intestine resulting in severe diarrhea with the presence of blood and mucus in the feces. Gastroenteritis, inflammation of the mucosa of the stomach and intestine associated with frequent loose motions with or without blood, usually accompanied by vomiting and pain in abdomen. So, it is usually diarrhea associated with vomiting. Food poisoning is a syndrome characterized by diarrhea with or without vomiting and associated with consumption of food contaminated with microorganisms or microbial toxins. Now, we have just seen what is the definition of diarrhea, that is a passage of 3 or more loose or liquid stools per day. It often lasts for a few days and can result in dehydration due to fluid loss. It is usually a symptom of an infection in the intestinal tract, which can be a parasite, a bacteria or a virus. Globally, about 2 million cases of diarrheal diseases occur each year, and almost 5,25,000 children under the age of 5 years, mostly in developing countries, die from diarrhea. Diarrhea due to infection is widespread throughout the developing countries. Each episode of diarrhea deprives the child of nutrition necessary for growth. As a result, diarrhea is a major cause of malnutrition in developing countries. Diarrhea is transmitted through the fecal oral route, through contamination of food or water, or person to person spread in overcrowded places with poor personal hygiene. Transmission occurs through the 5 F's, that is fingers, flies, fields, fluid and food. If you look at this, this is called as the F diagram, where the 5 F's are demonstrated, that is fingers, flies, fields, fluids and food. Now, if you want to prevent the transmission of diarrhea, the vertical lines show where all the transmission of diarrhea can be prevented. The first vertical line shows essentially the toilets, creating toilets and preventing open air defecation can prevent the spread of diarrhea in the community. The second vertical line shows that safe water supply, which is not contaminated by feces, is an important way of preventing diarrheas. The third vertical blue line shows hygiene. Hygiene, and so you prevent flies sitting on your food and you prevent fecal contamination of food and water. And the last most important one is hand washing. Because of appropriate hand washing, the cycle of fecal oral transmission can be broken and we get less incidence of diarrheas. The clinical presentation will vary depending on the site of pathology. In a small intestinal pathology, large voluminous stools without obvious blood or pus are present. In large intestinal pathology, frequent small volume stools with obvious blood and pus are present. The pathogens causing diarrhea are essentially the bacteria E. coli, Vibrio cholera and Shigella, and the other bacteria shown in the chart there. The viruses are the Norwalk virus, the rotavirus, the adenovirus, astrovirus, calcivirus, coronavirus and the enterovirus. Among the parasites, the common parasites are Entamoeba histolytica, Giardia lamblia. In the immunocompromised host, Cryptosporidium, Cyclospora and Isospora are common pathogens. Sometimes diarrheas can occur because of non-infective causes. This occurs usually in chronic diarrheas. Examples of these are the inflammatory bowel disease, which can present as ulcerative colitis or Crohn's disease. Impaired nutrition or malabsorptive diarrhea can also occur, and an impaired digestive function diarrhea which occurs in celiac diseases. Drug-induced diarrhea can occur if excess intake of laxatives have been taken or following intake of antibiotics. Endocrine causes of diarrhea are Addison's disease and carcinoid tumors, and sometimes the manifestation of a gut cancer can also be as diarrhea. Now, let us see a case of diarrhea presenting to the OPD. A 3-year-old male child was brought to the OPD with complaints of passage of frequent watery stools and fever of 1-day duration. The mother was worried because the child had been passing just water from yesterday. On examination, patient showed mild dehydration, pulse 110 per minute, blood pressure was 90 by 70 millimeters of mercury, temperature of the child was 100 degrees Fahrenheit. All systemic examination showed no abnormality. The child was admitted for observation and IV fluids were started. He was advised stool examination for ova and parasites, bacterial culture and sensitivity, and a rotavirus antigen test. The important thing was the sample collection. The patient's mother was given a sterile wide mouth container to collect the stool sample. The request form was filled with details like age, sex and name of the patient, ward of the patient and time of collection of sample. The sample was labelled again appropriately with name, age, sex and registration number. The mother was instructed how to collect the stool sample. She was told to collect a freshly voided sample. The volume of the sample should be at least 1 teaspoon in a liquid stool sample or a pea-sized piece of formed stool. The sample should be collected before administration of any antibiotics to the child. The stool is to be collected in a wide mouth sterile container and sent to the laboratory immediately for microscopy and culture. Some of the stool was transferred to a carry-Blair medium for transport to the bacteriological laboratory. Macroscopic examination of the stool at the bedside showed scanty fecal material, plenty of mucus in stool and watery stool. In the laboratory, once it reached, stool microscopy was done by wet and iodine mounts. No parasites and eggs or cysts were seen in the stool. Motile bacteria were seen, a few pus cells and no RBCs were detected. The gram stain showed gram negative bacteria in stool. ELISA for rotavirus antigen test was negative, so rotavirus was excluded. In the bacteriology laboratory, plating was done on McConkey's agar and deoxycholate citrate agar and incubated aerobically at 37 degrees for 18 hours. After overnight incubation on McConkey's agar, pink colored colonies were seen, indicating that the organism was a lactose fermenter. So, this is easy to differentiate from other pathogens of the intestinal tract which are non-lactose fermenters. So, these are the lactose fermenter colonies of the organism which was isolated from the patient. No colonies were seen on deoxycholate citrate agar. This is a selective medium used to select out the E. coli from the medium, so that you can get the enteric pathogens. In this case, since the pathogen was E. coli, no growth was seen on deoxycholate citrate agar. Colony smear showed gram negative non-sporing rod shape approximately 1 to 3 microns in size by 0.4 to 0.7 microns in size. Hanging drop preparation showed a motile organism. It was likely that the organism had a peritrichous flagella because the organism moved majestically. The organism was identified by standard biochemical reactions. The tests which were initially done were catalase which was positive, oxidase was negative, nitrates were reduced to nitrites. This placed the organism in the family Enterobacteriaceae. Because it was placed in the family Enterobacteriaceae, the IMVIC tests were done. In the IMVIC test, the results were plus plus minus minus, indicating that the organism was indole positive, MR positive, VP negative, citrate negative. The organism was also H2S negative and urease negative. The sugar fermentation was tested on triple sugar iron agar. This is a medium which is generally used for testing of sugar fermentation. It contains 3 sugars, and if fermentation of all the 3 sugars occur, you get an acid butt and an acid slope, which is indicated by yellow color of the butt and the slope. So, this particular organism gave us an acid butt and an acid slope. That means, all the 3 sugars had been fermented. Triple sugar iron agar can also be used to detect H2S. So, if there is H2S production, it gives a black color in the medium. This particular organism did not give us any H2S production. So, there was no black color in the medium. If a sugar is not fermented, color of the medium stays pink in color. So, the final report of the patient given to the patient was Escherichia coli isolated. It was sensitive to ampicillin, trimethoprim sulfamethoxazole, ciprofloxacin, norfloxacin, gentamicin. So, though the sensitivity was available, the patient was improving on IV fluids. No antibiotic was given to this patient. The antigenic structure of E. coli. The E. coli has got surface capsular antigen, though it does not have a clear cut capsule, but it has got capsule material on the surface which gives it a K antigen. The O antigen is the somatic antigen which are numbered from 1 to 170 depending on variations in the structure. The flagell antigen or the H antigen is again numbered 1 to 70 depending on changes in the antigenic structure. Fimbrial antigens are present, but they have no role to play in classification. Isolate was sent to Central Research Institute Kasauli for serotyping. It was identified as E. coli O55 K24H2. So, that is how the isolate is numbered after serotyping. This strain was likely to be an enteropathogenic E. coli. Now, let us see what are the virulence factors of this organism which made it more prone to cause diarrheas. The somatic lipopolysaccharide of the organism protects it from phagocytosis and bactericidal activity of complement. So, the immune system of the body is not able to act on the organism. The fimbria helps it in initial attachment and colonization. The hemolysins also help it to destroy the cell membranes. The enterotoxin, heat labile, heat stable and virotoxins are all produced by various E. coli, so which can also help in causation of diarrhea. Let us see in brief what are enteropathogenic E. coli. They cause diarrhea in children and are characterized by low grade fever, malaise, vomiting and profuse watery diarrhea. Enteropathogenic E. coli usually occur as outbreaks, but they can sometimes occur as sporadic illnesses also. In our particular patient, we had profuse watery diarrhea, but no vomiting, but vomiting could be a symptom in enteropathogenic E. coli. The common serogroups which are present in the enteropathogenic E. coli are a little later ones, such as the O26, 55, 86 and so on. Diarrhea is usually caused due to malabsorption and destruction of the microvilli. They adhere to the intestinal enterocyte by a colonizing factor antigen which is present on the fimbria, that is the CFA. Now, after they adhere, so this is a bacteria sitting on the villi of the intestine. So, after intimate adherence occurs between the bacterium and the epithelial cell membrane, marked cytoskeletal changes occur, including accumulation of polymerized actin directly beneath the bacteria. So, these are all actin which are being produced below the bacteria, beneath the adherent bacteria, and this results in effacement of the microvilli, and the microvilli are destroyed, resulting in diarrhea. EPEC can be diagnosed essentially only by PCR. We look for genes. The genes that we look for are, first is the EPEC adherence factor, the gene for this, which is a plasmid encoded protein, and the gene for the locus of enterocyte effacement, because the enterocytes get effaced, the villi on the surface get effaced. This is a chromosomally coded gene which is the EAE gene. Both these genes can be detected by PCR and the organism confirmed to be a enteropathogenic E. coli after it is fitted into the right serotypes for enteropathogenic E. coli. Now, apart from enteropathogenic E. coli, there are 4 more diarrheogenic E. coli. They are known as the EHEC or the enterohemorrhagic E. coli, the ETEC or the enterotoxigenic E. coli, EAEC or the enteroaggregative E. coli, and the EIEC or the enteroinvasive E. coli. So, overall there are 5 diarrheogenic E. coli if you include enteropathogenic E. coli with these. The enterohemorrhagic E. coli generally presents with watery diarrhea and is associated with hemorrhagic colitis. It is usually food and waterborne and causes large outbreaks. The major virulence factor which causes this is the virocytotoxin or the VT toxin as it is often referred to. The ETEC produces a watery diarrhea very similar to the cholera diarrhea. It is present in children and it also causes traveller's diarrhea for people travelling from the developed world into the developing world. The virulence factors of the ETEC are the 2 toxins, the heat stable toxin and the heat labile enterotoxin. The enteroaggregative E. coli produces diarrhea with mucus, it produces childhood diarrheas and the virulence factor here are pili and cytotoxins. The enteroinvasive E. coli causes diarrhea just like the Shigella diarrhea, it causes dysentery. So, there is blood in the stool, could also present as watery diarrhea, it is usually food borne and there is actual invasion and destruction of the intestinal enterocytes. So, these are the 5 important diarrheogenic E. coli. Now, let us see each one of them in detail turn by turn. The enterotoxigenic E. coli, which is similar to the clinical manifestations of cholera, though it is not as severe as cholera. It is endemic in developing countries and in the tropics. Traveller's diarrhea is when persons travel from the developed world to such countries, they get infected by this enterotoxigenic E. coli and they get diarrhea. So, the manifestations of the disease can vary from mild disease to fatal disease, as I said, resembling cholera. The usual serotypes are again the earlier serotypes O6, O8, O15, O25 and O27. Pathogenesis, first there is an adherence of the E. coli to the membrane by fimbria by using the colonizing factor antigen. Then there is the production of the two types of toxins, that is the heat labile and the heat stable toxins. Now, let us see how this actually occurs. Now, this is the E. coli in the intestinal tract. This E. coli produces the toxin that is the enterotoxigenic E. coli, which has got 5 B components, which are the binding components, and the 2 A components, which are the active components, which are called A1 and A2. Once the binding components have bound to the ganglioside receptor on the enterocyte, the active components enter into the cell of the intestine. Now, once they enter into the cell, the A1 and A2 dissociate. The A1 is responsible for increasing the adenylate cyclase activity of the cell, resulting in increase in cyclic AMP within the cell. This increase in cyclic AMP results in an outpouring of sodium, water, chlorides, bicarbonates and potassium into the lumen, resulting in diarrhea. So, this is the mechanism of action of the enterotoxigenic E. coli. Now, difference between the heat labile and the heat stable toxin are, the heat labile toxin is a powerful antigen. So, it can be detected by most common serological tests because it produces antibodies. The heat stable antitoxin is a poor antigen, so it is little more difficult to detect. The heat labile toxin activates adenyl cyclase, like I have just shown you, increasing the concentration of cyclic EMP in the cell, while the heat stable toxin increases the concentration of cyclic GMP within the cell, and there is hypersecretion of water and electrolytes into the lumen of the cell, resulting in diarrhea. The heat labile and the heat stable toxin can be differentiated on the basis of various tests. Initially, it was done only using animal models. The rabbit ileal loop was externalized. 1 ml of liquid culture was injected into the rabbit ileal loop. If the culture was producing a heat labile toxin, there was a ballooning of the loop. Otherwise, the loop would not balloon, it was likely to be a heat stable toxin producing E. coli. The suckling mouse was injected by the intragastric route. There was no diarrhea if heat labile toxin was being produced, and there was diarrhea only in the presence of heat stable toxin. This was then replaced by cell culture techniques. The cell cultures which were used were the adrenal cortical cell cultures and the Chinese hamster ovary cultures. Now, both these cultures showed some sort of a cytopathogenic effect in the presence of heat labile toxin, and they showed no cytopathogenic effect in the presence of heat stable toxin. The adrenal culture showed rounding of the cells, while the Chinese hamster ovary culture showed an elongation of the cells. Simpler methods are the immunological methods which can be used, such as the ELISA, the latex agglutination test or immunodiffusion test. The Beacon's test is used to differentiate between labile and the heat stable toxin. In this, the antitoxin is streaked across the center of the medium and the culture is streaked at right angles to it, very similar to the way we put up the LX test. A line of precipitation is seen at the junction of the isolate where it meets the antitoxin. You will see a line which shows a line of precipitate indicating that the heat labile toxin has been produced. This line of precipitate will not be seen with the heat stable toxin. The newer methods are by using DNA probes specific for the heat labile toxin and for the heat stable toxin. The next E. coli which is diarrheogenic, which we will be studying today, is the enterohemorrhagic E. coli. It gives rise to diarrheal disease ranging from mild to fatal hemorrhagic colitis and can result in the hemolytic uremic syndrome, which is invariably fatal. It is commonly seen in children and very elderly populations. Common serotype which causes this enterohemorrhagic E. coli is O157H7. Occasionally, the O26H1 can also cause enterohemorrhagic diarrheas. The enterohemorrhagic E. coli produces diarrhea by production of a virotoxin or a Shigella-like toxin, which are referred to as VT or SLT. This particular toxin is phage encoded. It acts on the vascular endothelial cells and causes capillary microangiopathy. It is also composed of A and B subunits, but they act by inhibition of protein synthesis within the enterocyte. The diagnosis of an enterohemorrhagic E. coli can be done by demonstration of the E. coli which are causing enterohemorrhagic disease. This can essentially be done by using a sorbitol McConkey agar for screening. The E. coli do not ferment sorbitol, and so they will give pale colored colonies on sorbitol McConkey agar. So, this is an easy test to pick up an enterohemorrhagic E. coli. Demonstration of the virotoxin in feces can be done by seeing the cytotoxic effect of the virotoxin on viro or HeLa cell lines. DNA probes for the VT1 and the VT2 genes can also be used for diagnosis, and a test for the anti-lipopolysaccharide O157 antigen by immunoblot can also be done. So, all these can be used for diagnosis of an enterohemorrhagic E. coli, which is often an emergency because it comes in large outbreaks. The next diarrheogenic E. coli which we are studying today is the enteroinvasive E. coli or the EIEC. Now, these have a capacity to invade the intestinal epithelial cells and cause tissue damage. This ability is determined by a large plasmid. Clinically, the infection resembles shigellosis or dysentery caused by Shigella, and there is blood and mucus in the stool. Patient presents with tenesmus and fever. The serotypes which cause enteroinvasive E. coli are the later serotypes after O124, and they can be O124, 136, 143 and so on. The organisms are non-motile, and so they are atypical E. coli and resemble more the alkylaceins dispar group. The pathogenicity of the organism is shown in the figure. There is penetration of the epithelial cells by the E. coli. It is endosomed into a vacuole. The vacuole enters into the cell, then it is released from the vacuole and the bacteria multiply in the cell and they spread to the adjacent cells. As they spread to the adjacent cells, they will also multiply in the cell. As they keep multiplying in the cell ruptures and the bacteria are released back into the lumen. As they are released back into the lumen, they will also cause a release of pus cells, white cells, RBCs and cell debris. So, this is what you see in the diarrhea caused by this particular organism in the stool of the patient. Now, you can pick up that this particular E. coli is the enteroinvasive E. coli. Apart from the clinical symptoms, you will get the isolation of an atypical E. coli from stool resembling the alkylation dispar group, that is, it is non-motile and it may not ferment sucrose. Now, this was originally diagnosed as enteroinvasive E. coli by using an animal pathogenicity test called as the Serenese test. So, there was installation of a suspension of organisms into the eye of a guinea pig, resulting in mucopurulent discharge in the eye. In this picture, you can see the eye of the guinea pig with the mucopurulent discharge in the eye of the guinea pig. Now, these tests are not now commonly done because many animal experiments have now been prohibited. Cell penetration of HeLa and Hep2 cells are now generally used for diagnosis of enteroinvasive E. coli, or you can do a demonstration of the IPA gene by PCR. Enteroaggregative E. coli is another E. coli which causes diarrhea. It is named because they appear in a stack of brick formation on either Hep2 cells or even on a normal glass. They are associated with persistent diarrhea in developing countries. Usually, the O antigen is untypable in these strains, H may be typable. So, this is the cell wall of the enterocyte showing the stack up of the enteroaggregative E. coli on the surface of the cells of the enterocyte. Now, how does this enteroaggregative E. coli cause disease? First, there is colonization of the intestinal mucosa because of aggregative adherens fimbria. This is also plasmid encoded. So, it gets colonized on the surface because of this fimbria, then they form mucoid biofilms on the surface. So, this is like the biofilms being formed on the surface of the enterocyte, then they elaborate enterotoxins and cytotoxins resulting in mucosal inflammation. So, this enteroaggregative heat stable toxin is the most important toxin here, which results in fluid secretion. This is related to the heat stable toxin of the enterotoxigenic E. coli. So, this is the mechanism by which the enteroaggregative E. coli causes diarrhea. Apart from this, extraintestinal infections can also be caused by E. coli, though we are focused today on the diarrheogenic E. coli. E. coli can cause other infections also, which we will be seeing in various other sections as we deal with them. Urinary tract infections, septicemia and meningitis are some of the other common infections caused by Escherichia coli. Now, how would you manage a patient of diarrhea? Most E. coli infections resolve spontaneously and require no antibiotics. In fact, in an enterohemorrhagic E. coli infection, if antibiotics are used, it can precipitate a hemorrhagic uremic syndrome, which is invariably fatal for the child. So, antibiotics should be avoided in most E. coli diarrheas. Antimicrobes known to be useful only in the case of traveller's diarrhea include doxycycline, fluoroquinolones, trimethoprim sulfamethoxazole. They shorten the duration of diarrhea by 24 to 36 hours and so are recommended for traveller's diarrheas only. Supportive treatment is required in most diarrheas to prevent dehydration. This is quickly required if the patient becomes dehydrated. Patient becomes anemic, appropriate therapy would be required. Patient should be given normal food so that he recovers, does not land up with anemia, and he must be observed to see that he does not develop hemorrhagic uremic syndrome. Antimotilytic agents are contraindicated in children and persons with enteroinvasive infection or the EIEC infection. So, even antimotility agents are contraindicated in these patients. So, essential basis of therapy is giving enough fluids and maintaining hydration of the patient. These are the references for the figures which I have used in the presentation. They have been taken off the internet, and I would like to thank all the authors of all these figures whose figures I have used for this academic presentation. I would also like to thank the Department of Microbiology, PJ Government Medical College, Bacteriology section, from which some of the figures have been taken. So, these are again some references for the figures used in the present presentation. Thus, I would like to conclude this particular presentation with a take home message that it is very important to wash your hands properly and keep your hands clean. It will not only prevent diarrhea in yourself, it will also prevent diarrhea in the community. Thank you.